sponsored by the Association of Maternal and Child Health Programs and the National Institute for Healthcare Management Foundation. My name is Carolyn McCoy, and I'm a Senior Policy Manager at AMCHP. On behalf of both AMCHP and NIHCM, I am delighted that you are joining us for this exciting webinar. But first, I'd like to review a few housekeeping items before we proceed with the presenters. At this time, all phone lines should be in listen-only mode. Please do not unmute your phone lines throughout the presentation. If you are having any technical difficulties with your audio, please use the chat feature and the AMCHP staff will be able to help you. If you need to step away from the phone, please do not put the call on hold, but simply hang up and join the call again when you are able. We will have a brief question and answer period at the end of the webinar, and we invite you to submit questions through the call by using the chat box feature on the upper right-hand side of your screen. Today's call will be recorded. The recording and slides will be available on the AMCHP website within 1 week of this broadcast. Following the webinar, you will receive a link to a brief survey. Your feedback on the survey will assist us with informing our future efforts, so we ask that you do please take a moment to complete it. I'd like to thank Emily Eckert and Katherine Santoro for their help on bringing this webinar to you all. And lastly, by November 2nd, you will receive an additional email with the link and the full set of slides, supplemental reading materials, and the recorded webinar that you can share with your colleagues who may be interested in the information but were not able to attend today. I'd like to now invite the AMCHP CEO, Lori Tremmel-Freeman, to say a few words about today's event. Lori?
Good afternoon, everybody. Thank you, Carolyn, and hello to all of our participants today. The Association of Maternal and Child Health Programs is a national resource, partner, and advocate for state public health leaders working to improve the health of women, children, and families, including those with special health care needs. We are very excited to bring this webinar to you, and AMCHP is grateful for the funding from HRSA, the Health Resources and Services Administration, and the Maternal and Child Health Bureau for this project. The Alliance for Innovation on Maternal and Child Health, expanding access to care for maternal and child health populations. This project funds AMCHP in coalition with the Association of State and Territorial Health Officials, the National Academy for State Health Policy, the American Academy of Pediatrics, the National Governors Association, and the National Conference of State Legislators for a 3-year project. AMCHP and the other grantees are working together to achieve significant impact in 3 focus areas: strengthening continuity of care and coverage in care for pregnant women and children, improving systems of care for children and youth with special health care needs, and promoting implementation of Bright Futures. This program will be evaluated by the Anthem Institute. Today's webinar, co-presented by the National Institute for Healthcare Management Foundation, will focus on coverage and care for pregnant women. I hope you enjoy it and that you'll share the information with your colleagues. Thank you.
Thank you, Lori, for that wonderful overview of AMCHP's work and the AIM Access Project. I'd like to review quickly what we will cover for this webinar. By the end of today's webinar, participants will be able to summarize the leading causes of pregnancy churn in a post-reform insurance landscape, navigate private and public insurance options for pregnant women and postpartum women, and address issues of continuity of coverage and care for pregnant and postpartum women, and explore opportunities for improvement at the state level. We've asked Dania Palanker from the National Women's Law Center to start with a presentation on pregnancy churn and coverage options for women. She will be followed by Shea of Anthem Incorporated, who will discuss the role of health plans in making sure women are covered before, during, and after their pregnancy. Lastly, we will hear from Todd Slettvet of the Washington State Healthcare Authority about state efforts to improve continuity of coverage and care for pregnant and postpartum women. As noted earlier, we will have ample time for questions and answers at the end of the presentations. Please be sure and send your questions in throughout the webinar, just using the chat feature anytime. And Katherine Santoro from NIHCM will be our host for the question and answer session at the end. So as you're hearing information, and as questions come to mind, please feel free to go ahead and chat those in. So to get us started, I would like to introduce our first presenter, Dania Palanker. She is the Senior Counsel for Health and Reproductive Rights at the National Women's Law Center. Dania, if you can make sure your line is not muted, I will hand things over to you.
Well, thank you, and I'd like to start by thanking AMCHP for hosting this webinar and inviting me to participate. It's a very important issue as far as many of the pieces I'll talk about how we have closed many gaps in coverage for pregnant women with the Affordable Care Act, but it is very important to realize where those gaps may continue to exist or where people might transition between coverage, so basically where they may churn either off of a coverage that they currently have or churn between coverage. So on the next slide, you'll see my overview of the outline, which I just want to sort of do quickly, where I'll start by talking about what coverage looked like for pregnant women before the Affordable Care Act coverage expansions and protections were fully implemented. Then I'm going to talk about what those improved options for pregnant women are, and then sort of walk through some examples of sort of how, where we are now with coverage options, where the opportunities for churn are, and basically where a woman might drop out of coverage completely, or whether she may have an option to change coverage, or even sometimes, may otherwise find herself being moved in coverage if she doesn't take action, and how that can impact pregnant women and women in their postpartum. So on this next slide, I talk about how women got coverage in 2013. And basically, you can see that that really big part of the circle is employment-based coverage. And before the Affordable Care Act, after the Affordable Care Act, basically, in America, this is the largest base of coverage for adults is employment-based, and specifically, this is women aged 18 to 64. So it's non-Medicare aged women. And besides employment-based, the next largest piece of the pie was unfortunately uninsured. And then you have remaining direct purchase, which is pretty based mostly the individual market, people who are going and buying insurance on their own, Medicaid, and other government insurance. And this is looking at all women. If we were able to look more closely just at pregnant women, that Medicaid piece would be significantly higher because many states do have higher levels of Medicaid coverage for women during pregnancy than they have for otherwise for adults or parents. So pregnant women, do get more of their coverage from Medicaid than other women or other adults. And on the next slide, I walk through what basically those coverage options were starting in 2013 for an uninsured pregnant woman. So if there was a woman before all the ACA expansions happened in protections who was uninsured, became pregnant, she really didn't have extraordinary choice as to where she could get coverage. She could get coverage on Medicaid if she was eligible, and that could happen once she was found out she was pregnant, and in fact, she may not be eligible for Medicaid until she's pregnant. In some states, and particularly this is an option for some immigrant women who aren't otherwise eligible for Medicaid, pregnancy services may have been covered through CHIP, the Children's Health Insurance Program. And if available to a woman when she was pregnant, she might be able to get onto employer-based coverage. However, unlike Medicaid and CHIP, you can only enroll in employer-based coverage either during your employer's open enrollment period or if the woman had a special enrollment period. And pregnancy itself is not a special enrollment period. The birth of the child is, so you can get the postnatal care and add the child on to coverage or make changes to your employer-based coverage when the child's born, but not during the pregnancy. The other piece with employer-based coverage is that there were, before the Affordable Care Act, pre-existing condition exclusion periods. So if a woman had already had a gap in coverage, she's uninsured, and she enrolls during her open enrollment period, or perhaps she gets married and has a special enrollment period, they might have still not covered her pregnancy if she had a long enough gap in insurance and she was not in a state that otherwise did not allow those exclusionary periods. So that leaves sort of what happens with the individual market. And really, the individual market, before the Affordable Care Act, there were numerous barriers to coverage, and even more for pregnant women. First, pre-existing conditions were excluded. So even if a woman were able to get coverage when she was pregnant in the individual market, they would be unlikely to cover the pregnancy if she was pregnant when she enrolled. And that could even, be she didn't know she was pregnant until after she enrolled, and they might still refuse to cover that pregnancy. And she may also not get covered at all because she had a pre-existing condition, which may have been a previous C-section, a history of asthma, of diabetes. The list can go on and on of what was considered a pre-existing condition. She may not have been able to afford coverage because there was rating for both gender, so women were charged more, and people with health conditions were charged more. So the woman may not have been able to afford individual coverage. And even if she sort of did and finally was able to enroll in coverage, in 2009, only 13% of the health plans available to a 30-year-old woman in the individual market provided maternity coverage. So that individual market coverage usually excluded all maternity care. So sometimes what would happen is a woman had the coverage, she wasn't even uninsured, and when she went to have her first maternity costs paid for, found out that that coverage was excluded. And while you could purchase maternity riders to basically add the maternity coverage, they were often thousands of dollars, and they would often have a 1 or even 2-year waiting period, so that the idea was you had to pay into it for a period of time before they would start paying for any maternity care. So if you were pregnant, it was almost impossible really to get individual market coverage and get it to cover your maternity costs. And so then the Affordable Care Act changed this, and one of the big pieces was the pre-existing conditions. There was many more, as I talked about. And so now I want to walk through some of the protections for pregnant women post-ACA. There's guaranteed enrollment and renewal of coverage, which means that a woman doesn't have to be worried that she will not be offered coverage because she's pregnant or has had a past complicated pregnancy. And pre-existing conditions aren't excluded. There's limits on rating, so insurance plans can't rate charge more to women. They can't charge more to people with health conditions. Maternity is covered in all individual market and small group plans, and that coverage is for all the enrollees, including all dependents. There is sort of one remaining gap, which is for larger employer plans. Many large employer plans, while they do have to provide maternity for the enrollee and the enrollee spouse because of the Pregnancy Discrimination Act, the Pregnancy Discrimination Act did not specifically require maternity be provided for dependent children. Basically, it's just male employees cannot be offered different dependent child coverage than female employees. So you cannot offer a dependent maternity to all of your employees' children, and that's okay. So that's sort of the remaining sort of private insurance gap that's out there. Many prenatal services are preventive services without cost sharing, and that includes some office visits, tests such as gestational diabetes. That applies even to dependent children that might not otherwise have maternity if they're in a non-grandfathered plan. And although not on this slide, it also includes breastfeeding support and supplies, which is important postnatal services, where postnatal, a woman can get a breast pump without cost sharing and lactation counseling. And in fact, the administration just last week issued some new guidance sort of clarifying the access that women have to lactation consultants, and that plans must have a network and must find a way for women to get to these providers. And there's also things to help low-income women afford the cost of coverage on the exchanges, and there's pieces that limit the overall cost sharing. So if a woman is enrolled in coverage and has a very expensive, complicated pregnancy, she's not going to be left with $20,000, $30,000 of that bill if she's got coverage that has these cost-sharing protections. So now I want to look and compare our 2013 chart to our 2014 shot and see that while overall it may look like things haven't really changed, the employment base is still the most. When you look at the sort of upper left side, those three pieces of the pie, that's where the change happened. And so if we look more closely at those, I have a bar chart that shows on the next slide, actually comparing the direct purchase Medicaid and uninsured from 2013 to 2014. And you can see that that direct purchase on Medicaid really increased significantly in that 1 year with the new Medicaid coverage and the opportunities to enroll in the marketplace, and the uninsured rate went down. So where that leaves us is sort of a question of when can a pregnant woman enroll now that we're sort of in a new realm. She can enroll in Medicaid anytime if she's eligible. I mean, absolutely anytime she goes to Medicaid, if she's eligible, if she's pregnant, if she's not pregnant, if she, it could be January 15th, it could be July 15th, it doesn't matter. The marketplaces and employer plans have limits. So in both of them, there's open enrollment periods, and the marketplace enrollment starts in just a few days. You can, in both of them, enroll with special enrollment periods. So if you lose other coverage, for example, if a woman is pregnant, as I'll go through this, 60 days postpartum, if she has Medicaid for pregnancy-related coverage, that coverage ends, but she can then enroll in the marketplace. Marriage, divorce, or birth or adoption of children are special enrollment periods. And employer plans also have an enrollment period for someone who's newly eligible, sort of a new enrollee or someone who perhaps switches from part-time to full-time and newly becomes eligible. So that's when women can enroll. Then the question is, when can a pregnant woman lose coverage? And that can be, with Medicaid, she can lose that when she loses eligibility. So for pregnancy-related coverage, that's 60 days postpartum. Other time, Medicaid that might be related to someone's income. In the marketplaces, you have to act at any time somebody can disenroll from coverage. You can also lose coverage if you fail to pay your premiums. There's a grace period, but if you just are not paying those premiums, you will eventually have that coverage ended. And you can also lose coverage if the issuer leaves the market, which is generally only happening at the start of plan years. But that means that some women, if they don't take action during open enrollment, might lose coverage as some of the issuers, including many of the co-ops, are not going to be offering next year. And then employer plans, you can really only actively disenroll at an open enrollment or a special enrollment. And you might also lose coverage if you change jobs, you left your employer, or you might have switched from a full-time position to a part-time position. Or an employer might cancel a plan. And while we don't hear about this often, there are times where an employer their plan might run out of money, and there have been cases where they've just sort of canceled plans in what should be the middle of a plan year. Unfortunately, that can happen, although it's not something we hear about a lot. So now I want to just sort of quickly walk through some of these things, and they're kind of complicated, but I'm really just trying to show people how sort of the process works. So if you have a woman who is pregnant and currently uninsured, she can just sort of stay uninsured. But when she becomes pregnant, if she meets the right eligibility in her state, she might be able to move on to Medicaid, and then she can actually stay on Medicaid through the birth until 60 days after her birth. And then if she does nothing else at 60 days after her birth, she's going to end up uninsured. She may move to regular or expanded Medicaid if she has a low enough income, or she may be able to move to employer or exchange plan. And you'll notice that that's sort of the if nothing happens, but in there's always other options, and particularly when you get pregnant, the only option is to move to Medicaid if eligible. But at giving birth, there's the option also to enroll in an exchange plan or an employer plan because there's a special enrollment period. And so the next slide, I talk about sort of the path for a woman who's not eligible for Medicaid. And you really see that, and she doesn't really get an option until that time at birth. That she's sort of, unless, and this is assuming there's no other special enrollment period that happens, she's really going to remain uninsured for her pregnancy. But she might be able to enroll in an employer plan or an exchange plan when the child's born. And then I want to show quickly what happens to someone in the Medicaid expansion program. And that's really that person can move, if eligible, may move to the Medicaid for pregnancy-related coverage, she may also remain in the Medicaid expansion. And then, as you sort of see, it's sort of the same steps after that, where at birth you have the opportunity to move to an employer exchange plan. And if you're in the she's in the Medicaid for pregnancy-related coverage, it's that 60 days later. And the final piece I want to walk through here is someone who's pregnant and they're on an employer coverage or an exchange plan, and they're very similar, so I kept them the same. And if that woman is eligible for Medicaid for pregnancy-related coverage and she wants to switch to that coverage, she can. If she isn't eligible, or if she wants to remain in the exchange plan, perhaps she would have to change doctors in Medicaid, she can also stay in that exchange plan. And then at birth, as usual, there's always that opportunity to newly enroll or change employer exchange plan. And if she goes the Medicaid route, that Medicaid for pregnancy-related coverage, again, will end 60 days after the birth. So if she doesn't actively do anything, she could end up uninsured there. And then I finally just want to touch on a few other potential disruptions for people to be aware of that might not be as regular. One is issuers leaving the marketplace, and as I said, there's been news over the last few weeks of some of the co-ops dropping, so there will, out of the marketplace, so there will be women who are going to perhaps it's that if they don't change, they don't get their premium tax credit because their insurer is still offering, but outside of the marketplace, or their insurer may be leaving the individual market altogether. There could be benefit changes for a new plan year. That can happen with employer plans. It might happen if the exact plan someone is enrolled in is canceled from the exchange or tweaks a little bit, and that could cause disruptions if cost sharing goes up and a woman faces unexpectedly high cost sharing. There can always be network changes that can happen, quite honestly, at any time during the year. So a doctor or a facility might drop out of network. And there's also always the chance for formulary changes, so that a woman who has to take medication for some complications in her pregnancy, if there's a formulary change, she may no longer be able to afford or may be surprised by the cost of medications, and that might impact her care. So that sort of meant as an introduction, somewhat detailed, but sort of the steps and the processes along the way of where to think about as far as churning and transition in healthcare. And I will give it back to our host from AMCHP.
Thank you so much, Dania, and I really appreciated those slides, especially with the chart, so you can follow the flow through the options for a pregnant woman. And I'd like to remind the participants that if any time you would like to download the slides and send them off to a friend, they're available in the additional resources pod. So you could kind of take those away and look at them even before we send the recording out, as well as the speaker bios and supplemental reading. So if you want to just take a look at those, I wanted to remind you all that those are there. So thanks again, Dania. That was a wonderful presentation. Now I'd like to introduce our next speaker, Katherine Shea. She's the Vice President of Maternal and Child Health Services at Anthem Incorporated. Katherine, if you could make sure that your line is not muted, I will hand things over to you.
Thank you, Carolyn, and good afternoon. Let me see if I can advance these slides.
Katherine, the arrows are down in the left-hand corner, if you can see that on your screen.
All right, that's good. All right, thank you very much.
Wonderful.
It's my pleasure to participate in this webinar, and I want to thank AMCHP and NIHCM for the opportunity and for their leadership on this topic. I have the good fortune at Anthem of leading a team of business leaders and clinicians specifically focused on meeting the needs of women of childbearing years, pregnant women, and their newborns. And I came to this position from the provider side with many years in the hospital setting. But I have since learned a great deal about the breadth and depth of managed care. So as we get started, I believe it's important to acknowledge that, many may consider the role that an insurance company plays. And what comes to mind first is, they pay hospital and physician claims. And that's all true. but there's so much more to be considered. So let me quickly
this program. It is a targeted case management program, so it's focused on connecting the family and the child to needed services. And finally, I'll talk just a couple minutes about our Medicaid Administrative Claiming Program. In our state, we contract with states or governmental entities to receive partial reimbursement for performing administrative activities that support the goals of Medicaid. This is a joint federal-state program that every state can opt to participate in, and it allows governmental agencies and their staff to receive partial reimbursement for things like outreach, for things like application assistance, for referrals, a variety of activities that support the goals of the Medicaid state plan. And it's been very helpful in our state. We contract with local health jurisdictions also, school districts, tribes, and other governmental agencies. And they participate in random moment time studies to determine what portion of their time is spent performing those activities, and it gives them an opportunity to at least receive some reimbursement for doing that work, and it's very important, especially the application assistance piece. So we have a variety of programs and services in our state that I think put us in a great position to ensure that pregnant women are receiving services and getting the help that they need, and we've included a resource page for you that you can go look and find more information about our First Steps programs, our MAC programs, the exchange, and so forth. So thank you very much.
Thank you so much, Todd. That was a wonderful presentation, and the program really does seem to give women, pregnant women in your state, that extra touch that they sometimes need. So thank you for sharing that. And I'd like to remind everyone that the slides and the speaker bios are available, as well as a supplemental reading that highlights Todd's program that AMCHP developed. It's available in the additional resources box. And also, please chat in your questions and answers box. I apologize for misspeaking before, but we're also able to see everything that kind of comes in, so we're grabbing everything as it comes in. So thank you all so much for contributing your questions and answers. Keep them coming. And I'd also, again, like to thank Dania, Karen, and Todd. So we really appreciate everybody taking the time to present. So in the time we have left, I'd like to have Katherine help us respond to the questions and answers. So I'd like to hand it over to Katherine Santoro, who's the Director of Policy and Development at the National Institute for Healthcare Management Foundation, NIHCM, to field questions from our presenters. Please note that if you may still submit questions using the question and answer box feature on your screen. We are not taking any questions and answers over the phone. Everybody is on mute. So again, please chat in your questions, and Katherine will kick off the question and answer session. Katherine?
Thanks, Carolyn, and I'd just like to echo thanking all of our speakers and our participants today. There's some great questions coming in. Since we just finished with Todd, there's a few clarifying questions for your presentation, so why don't we start there. The first question is asking if you can clarify or show an example of what a unit of service is in your First Steps maternity support program.
Sure. A unit is defined as 15 minutes of service. It's, as I mentioned, we used to have 60 units of service available to every single Medicaid pregnant woman. Once we had to go through budget reductions as part of the Great Recession, if you will, we targeted services to our higher risk clients, and we don't have as many units available, but we target them towards those clients with the highest risk of having a poor birth outcome. So it's 15 minutes is one unit of service.
Okay. And a few other questions on that same slide and on that program. Could you explain whether obesity is considered a moderate or high risk in terms of the eligibility for service?
Yeah, sure, I'd be happy to. And I have my section supervisor of our First Steps program available to help answer questions. But obesity is a risk factor. I believe it is one of our high-risk factors. So we use BMI. A woman over a certain BMI percentage is automatically determined as high risk. And this screening tool, I saw that question, is available, I believe, on our website. That's listed as a resource at the end of my presentation, and we have contact information there as well. So anyone that wants some additional information can feel free to contact myself or Stacy Bishaw, who's listed on our website as well. And the pre-pregnancy BMI greater than or equal to 30 and a weight gain within IOM guidelines. So yes, it is a high risk factor.
Okay. Another question was about the group services, and if you could explain who, or if those are led by providers, and who bills and who is paid for the group services that you mentioned.
Sure. Our MSS providers are the folks that bill for all of the units of service provided. And as I mentioned, in a group setting, we allow our providers to bill up to 1 unit per client in the group, and they can actually have that group last as long as they would like, but it has to at least be an hour. So they would just bill it by the client in the group service as a 15-minute increment, but they get to do that for every participant in the group setting.
Great, thank you. A little bit of a broader question for Todd and or Karen. How do you assess and monitor quality of care for the pregnancy-related services that you're offering? And can you share any information on quality measures that you use or outcome analysis?
So Todd, do you want to keep going?
I'll talk just for a second. We just do program monitoring. I have a couple program managers that are responsible for overseeing our First Steps program. So we do program monitoring to make sure that they're following our program rules and regs. We also have a First Steps database that's managed by our research and data analysis partners. And then many of those activities are assigned to our managed care office, working with the plans, but we just handle it by a provider-to-provider monitoring.
And in terms of monitoring quality for our population, and this is Karen, I do want to mention a couple of different options. And the first one being we partner and contract with multiple facilities through our QHIP program, Quality Health Improvement Project, and what we include is all payer data measures on the Joint Commission perinatal care measures for early elective delivery and low-risk C-sections, the NTSV rate. In addition, we pay very, very close attention to HEDIS measures, which would be the timeliness of prenatal care, that prenatal care visit occurring in the first trimester or within 42 days of enrollment, the postpartum visit date being within 21 to 56 days after delivery, and then frequency of prenatal care, the number of prenatal care visits that one of our members receives during the time of their pregnancy. And those measures, of course, are reported out on a quarterly basis in the form of report cards that are given to our providers so that they can see how they are tracking. In addition, providers receive information on their own particular preterm birth rate, their low birth weight rate, their utilization of 17P, their C-section rates, et cetera. So we do, monitor quality very, very closely. And then in addition, our state partners hold us accountable for these quality measures with premium withholds and liquidated damages if indeed those quality measures are not met.
Great, thank you both for that. We had one or two questions come in about incentives. One, I think, came in when Todd was just speaking about incentives for women participating in your maternity support program. Maybe we'll take that first, and maybe, Karen, if you want to mention, too, if there's any incentives in your maternity programs in terms of getting women in for care.
All I can say about incentives is that we leave that responsibility with our providers. We know from the research that group activities that offer clients incentives to participate tend to increase participation, and we've had those discussions, but leave that with the provider to make those decisions. Many of them go out into the community and find things like car seats for infants and other kinds of things that they often use as an incentive to get clients to participate in a group activity.
Mm-hmm. And as I mentioned, and this is Karen, that each state manages its program differently, but for the most part, we're able to provide women with up to $75 in incentives for participating in prenatal and postpartum care. Typically, $25 for receiving prenatal care in the first trimester, and then $50 for completing the postpartum visit. And then in addition, there are other incentives that are offered to mom for assuring that her child receives well child checks after, during the first year of life. And in addition, in some of our states, we also offer an incentive to women who complete more than 4 prenatal care visits in a group prenatal care setting. So, and then there are also, some states that do offer car seats or cribs to women who complete, so many prenatal care visits. The incentive program is available as a redemption program where mom sends in a redemption card, but it's also available in some states as a web-based option where mom can go to a website and record their activity and then receive an incentive. What's interesting about incentives, though, that I feel as though it's important to mention is that the redemption rate on the incentives that we offer is nowhere near what we'd like it to be. And in some respects, we do offer the incentive. We try to make it as easy as possible for women to achieve it, but the rate with which women interact and then actually receive the incentive is quite low.
Thanks, Karen. Another question that came in specific for you related to incentives. Could you tell us more about the incentives you mentioned for prenatal and postpartum care for providers? And also, how does that work if providers are dealing with women that are transitioning between different plans?
Mm-hmm. And so for providers who deliver the services that are associated with incentives, for the most part, the only way that we can determine whether the provider is due that incentive is that if we receive some kind of a notification from the provider through a claim that identifies the service that was delivered, or it's called an encounter code or a Category 2 CPT code. Frequently, a provider will then, submit one of those encounter codes on a claim, and we're able to then provide an incentive to the provider for having completed that service. And the dollar amount, of course, is going to vary by state.
Great, thank you. I'd like to go back to, and Dania, maybe you could take a stab at this or offer our participants a resource. There's some confusion about which prenatal services are supposed to be available post-ACA as preventative services without cost sharing. It seems to vary by state and across health plans. Is there a norm or a federal guidance or other resources specifically on this issue so people could better understand what should be offered across the different states?
Yes, so there is federal guidance. It does, so to start, specifically the ACA requirements apply only to new private insurance plans, so individual market and employer plans, and the Medicaid expansion. So you might see different things happening in different states in how they are covering either their traditional Medicaid or Medicaid for pregnancy-related coverage, because they don't explicitly have to provide the preventive services that were within the Affordable Care Act. But what the guidance says, and there are sort of two parts where the guidance is. If you quite honestly just Google HRSA for HRSA, Women's Preventive Services, you will get the initial list, the list that HRSA recommends, which is then what, through regulations, the way the statute is written, basically these HRSA regulations become what is required. And then there have also been some FAQs released by HHS along with other agencies on the CCIO website. You can find those. But specifically what the prenatal services are primarily screening services that have gotten an A or B recommendation in the United States Preventive Services Task Force. So they're screening such as for gestational diabetes, for anemia, Rh incompatibility, sexually transmitted illnesses. Also on there are things like folic acid. And where the office visits come in is that well-woman visits are a required preventive service. And well-woman visits, per the HRSA guidelines, really are services where you get other preventive services that have to be provided under the ACA. So if you're going into a visit to get the prenatal services that are preventive services, that office visit should also be considered a preventive service without cost sharing. There are some insurance companies that have gone further and actually made all prenatal without cost sharing, which is great. I think some others I've seen do what the insurance company calls routine prenatal services. And I say it's what the insurance company calls because there's no guidance around that. And sometimes that's because it was just easier for their cost sharing, I think, and others felt it actually was a good thing to do to get women that prenatal care and to get the prenatal care. But that means there are many services that are not expressly required under the regulation, under the guidance and the regulations. And there definitely is a difference, I would say, in how different insurance companies are interpreting it. But sort of the lowest coverage we've really seen that is in any way allowable is really where it's those specific screening services and just visits to get those services. And if I can also see if it's possible to get information out as a follow-up, I can sort of provide some of that guidance.
Great, thank you. Dania, you touched on this, but we'd be curious for all of the speakers' perspectives. What are the benefits and the arguments sort of for and against pregnancy triggering a special enrollment period for marketplace coverage? And can we expect to see any efforts at the state or federal level to make pregnancy a qualifying event?
This is Dania. I'll start. There definitely are efforts. There have been efforts in the state. However, CMS, HHS, CMS have said that they are limited by the statute and cannot, and that actually limits state actions too. So that for the exchanges for pregnancy to be an open enrollment period, they're saying would really require a statutory change. And there are some efforts. It's being talked about. I would say in some ways for policy, what I would see as not say a barrier, but a necessity to do along with any effort to try to create a special enrollment is we would want to see with that something that limits states' ability to roll back Medicaid for pregnancy-related coverage, because what we wouldn't want to see is a state say, oh, well, if pregnant women can enroll in the exchange. When they become pregnant, they no longer need the Medicaid benefit. And there are, very big cost-sharing differences between, and premium, too, because the exchange for most people will have some premium. And so if you're talking about, so we wouldn't want women who should be getting, comprehensive coverage that also might, in some states, include things like transportation or some of the coordinated care we've heard about on this call, sort of have that taken away, and instead, because a special enrollment period was put in. So that's sort of a important piece of the puzzle, that we wouldn't want women to lose one option because they gained another.
Thank you.
Dania,
Karen,
this is Karen. I definitely agree with you. I think that the cost-sharing issue is really, most predominant in my mind, that whereas under the Medicaid program, women become eligible, in some states as high as 300% of the federal poverty level, and then, having full benefits without cost-sharing, and then, moving in to a situation where it's actually going backwards, where they now need to pay a premium and then they have a cost-sharing responsibility is just, I think it's moving in the wrong direction.
Great, thank you. Karen, you had touched on this. I don't know if you have any additional thoughts, or if Todd or Dania want to share any perspective, but what are some of the state options to minimize coverage disruptions, and are any being used, some potential options that have been discussed in other venues, or bridge plans or premium assistance? Do any of you have any thoughts on other state options that could help address this issue?
Well, Dania may be able to speak to this better than I, but I do understand that within the Affordable Care Act there is the bridge plan, and we are implementing that program in New York. It's called the Essential Plan, and it will provide coverage above the 138% poverty level, and I think up to 200% for individuals to bridge between Medicaid coverage and the exchanges. And I see this as a good option for legal immigrants, as well as individuals who are having difficulty paying the premium under the exchange. But also, in my presentation, I did mention a few strategies that we could deploy that would help to avoid those gaps in coverage where we really are lacking in communication between the state and the enrollee, and the state and the managed care company, and the managed care company's ability to independently reach out to the enrollee to remind them to complete the redetermination process. Some states have a redetermination process that's more frequently than annually, and as we think about pregnant women and the number of transitions that they're going through, and the number of hoops that they must jump through in order to maintain their coverage, I think that decreasing those redetermination periods and making them much easier for members, and then also tightening the ability to communicate both in paper mail and electronically would really go a long way to decreasing the churn, the unnecessary churn.
This is Dania. I think the bridge plans are also called basic health plans, and they actually, I think there was an expectation that there was more interest in the state, and there hasn't really been a lot of adoption of those plans, but the idea behind them really was sort of being able to take some of the lower income people, instead of having the exchange, have the state-run plan that really does provide for those people who are the lower income and might really have the variability between plans. And so that's definitely one of the options. A state could always, if they chose to, provide financial assistance to people that were losing Medicaid eligibility, either based on income or if it was something to, women postpartum, whatever they wanted to break out, but they could provide additional federal financial or additional state financial assistance to make exchange plans available. But obviously that does cost the money of what the cost of that financial assistance will be. And specific for pregnant women and in that prenatal piece, I think a lot of it really is making sure women know their options before the child is born. And I say before the child is born because, her open enrollment period, well, she'll lose the Medicaid 60 days at the end of postpartum, but she actually will have an open enrollment period starting from when the child is born. And depending on what her medical needs are and her financial situation, she might not want to wait to the whole 60 days. She might have another health condition that she thinks will be covered better by another option that's out there. Or the other piece is you don't want her waiting until she's uninsured to then fill out the forms because then she'll have a gap in coverage. And we all know that those first weeks after pregnancy or after, having a child around are not necessarily the easiest weeks to probably add to your list of things to research health insurance. So as much as possible, communication as women, initially get on to Medicaid for pregnancy-related services and really throughout that process and even possibly through providers, getting them to sort of recognize that they should start doing research before the child's born about what their next step for health insurance is if they aren't going to be someone who will remain on Medicaid, if their Medicaid eligibility will end, really so that woman has the time to do the research. If there are other family members, work with other family members and try to figure out what the best options will be. Because if she waits until she loses her Medicaid, then she could end up going about 6 weeks or so without coverage before she enrolls in coverage and coverage actually gets started.
Great, thank you. Sort of teeing off of this discussion, we had a question about what tools or other efforts, especially surrounding health literacy, can help women sort of understand and make decisions about weighing the benefits or understanding the pros and cons of choosing Medicaid over qualified health plan coverage if they're eligible for both, and also in terms of what Dania was just saying, helping them decide what coverage will be best for their child as well. And could any of you talk about any of the efforts or resources that you're aware of?
Well, I think that what's most important is understanding that the woman who has current coverage, that her insurance company is aware of the terms of that coverage and whether she is going to lose eligibility and what the steps are that she needs to take in order to transition to a new plan or a new product, and interfacing both with the state and with the member or the woman early on, so that we don't have a gap in coverage. And it's really that tight communication between the agency that defines eligibility and the insurance company who is covering the individual, that all of the processes that are necessary in terms of forms that need to be completed, documentation that needs to be provided, have been completed in a timely way. And what it really comes down to is tightening that communication and making sure that we have the avenues for that communication to occur, whether it be a correct address, an email address, or an in-person encounter with someone who can help that woman complete whatever process it is in order to maintain her coverage and understand what her coverage options are.
Thank you. Todd or Dania, do you have anything to add to that question?
All I can add is that I think our in-person assisters in our state are available and trained to help our clients navigate through the qualified health plans, what benefits they offer in comparison to Medicaid, and they're just a resource to help the clients in that process.
Great, thank you. A question for Todd. In rural areas, it's often difficult to keep women enrolled in plans and make sure they're seeing the doctor. How does the Health Care Authority keep track of women in the more rural parts of your state that are moving through the system, and how do you ensure that they're moving between health plans where appropriate?
I'll let Melissa attempt to answer this question.
I believe a lot of the providers, they have, I think they're social workers that do a lot of talking with the gals that are, and giving them the options when they're about what to do when they're pregnant. And so we get a lot of calls and emails from the providers or the staff that work there, I guess, in financing, and they will ask us to assist them. So it sounds like on the clinic side and the hospital side, they have staff dedicated specifically for pregnant women to talk to them about what their options are and to make sure that once the baby is born, to make sure that they report it in the health plan finder to assure the newborn is enrolled, and then as well as looking in to see, if the mom, if maybe she's not eligible, can continue to make sure they have health family planning as part of the program. So I think that they have a lot of assistants out there in the clinics and hospitals that are really good at keeping them informed and in contact with us here at Healthcare Authority.
And the only other thing I can add is I agree there are quite a few rural areas in our state that are very challenging, not only in terms of providers available, but just continuing to keep in contact with pregnant clients. And as I mentioned in the presentation, we do have eligibility workers outstationed in every county and area of the state of Washington, so they are hopefully are able to help clients in navigating through the health plan finder to ensure that they continue to have coverage. We also have MSS providers almost in every county in the state of Washington, and that's another avenue to keep those clients connected through their local health departments, who are many of them are in-person assisters. And we also work closely with our tribal governments in the state of Washington. We have, I believe it's 29 federally recognized tribes, and many of them are in very rural areas in our state, and we stay well connected with them as well. And they also have tribal assisters. That's the equivalent of our in-person assister program.
Great. Well, thank you, and thank you to all of our speakers for engaging in this Q&A with us today, and I'm going to turn it back over to Carolyn at AMCHP now.
Thank you so much, Katherine, and you did a wonderful job wrangling all those questions. We had really great questions from the audience. We were so glad to see that engagement and curiosity about options for your state. So we hope you find this information to be valuable and that you'll share more information widely with your colleagues. I'd also like to remind participants that the link for the follow-up survey will be emailed to you shortly. Please complete the survey and also be on the lookout for an email containing the links to the speaker's slides, supplemental reading material, and the recorded presentation. Thank you all and have a great rest of your day.